Hi everyone, and in this video I'll be discussing about pharmacotherapy of rheumatoid arthritis. So, what are the drugs we use in the management of rheumatoid arthritis? So, before we begin this topic, what is rheumatoid arthritis? Rheumatoid arthritis is an autoimmune disorder. So, it's a autoimmune disorder, and second important thing is it mainly affects the female population and the joint stiffness, early morning joint stiffness, and after the joint stiffness, the patient will have deformities. So once the deformity develops, it's irreversible. So there is joint destruction. So when we manage rheumatoid arthritis, the main thing what we need to take care of is number one, take care of pain. Number two, take care of inflammation. Number three is to stop the disease progression. So pharmacotherapy of rheumatoid arthritis, it's an autoimmune disorder, so we have to suppress the immunity and take care of the pain and decrease the disease progression. So what are the goals of therapy in this thing, rheumatoid arthritis? Goals. The goals is to take care of the pain. Patient complains of pain in the joint, and as the disease progresses, patient will complain of stiffness. And if the treatment is not initiated, patient will have deformity. So deformities. And if the patient has deformity, he cannot do the day-to-day activities. So what are the drugs we use for the therapy? Number one, for pain, we use NSAIDs. So NSAIDs are non-steroidal anti-inflammatory drugs, and we call them as analgesics. So the most commonly used analgesics are diclofenac, then aceclofenac. You can use ibuprofen, but they will only provide temporary relief. Second class of drugs what we use is the corticosteroids. So corticosteroids what are used are the prednisolone, the methyl prednisolone. So methyl prednisolone. So why do we use corticosteroids? Corticosteroids, number one, it's an autoimmune disorder, so they have immunosuppressant property, and corticosteroids are anti-inflammatory. So these drugs have two important property. One is they have immunosuppression property. They can suppress the immunity. Number two, what they can have is anti-inflammatory property. The anti-inflammatory property, and these drugs can do this faster. But the only drawback is they don't modify the disease. They don't stop the disease progression. So even though they are faster acting, they don't modify the disease. They don't slow the progression. So the main therapy of steroid is bridge therapy. Now I will tell you what do you mean by bridge therapy. The meaning of bridge therapy is it's a temporary. So there are certain drugs which slow the progression of disease, and the third category of drugs in rheumatoid arthritis we call it as DMARDs. So DMARDs, the full form is disease modifying anti rheumatoid drugs. So these are called as disease modifying anti rheumatoid drugs, DMARDs. Now these drugs they don't act fastly. They are also called as SARDs. So SARD stands for slow acting. So slow acting anti rheumatoid drugs, and they modify the disease, and deformities will not happen with them. But they don't act faster. So until that, the steroids will act as bridge therapy. So in DMARDs, we have two important varieties: the drugs which are non-biological agents. So non-biological agents are also called as the conventional therapies. So which are used from so many years, the conventional therapies. Nowadays we have biological agents which can be used in the therapy of rheumatoid arthritis. So first of all, let me discuss what are the conventional drugs, and next I will discuss What are the biological agents used as DMARDs in rheumatoid arthritis? So first of all, let me take up the conventional or non-biological DMARDs. So the most commonly used drug in rheumatoid arthritis is a drug by the name methotrexate. The name is methotrexate. This is the first one which most of the rheumatologists will start. The mechanism of action is it inhibits an enzyme called dihydrofolate reductase. So it inhibits the enzyme dihydrofolate reductase. The specialty of the drug is it has anti-inflammatory property. The drug has anti-inflammatory property. And also, being an anti-cancer drug, it suppresses T cell and B cell, so it has immunosuppressant property. Immunosuppressant property. So because of this, the drug is initiated in the beginning. But two important adverse effects what we can face with that is it decreases the folate, so it can lead to megaloblastic anemia. So how do you overcome that? So you will give folic acid supplementation, so that will help us to overcome the adverse effect, that is megaloblastic anemia. So one of the beautiful drug, the conventional drug methotrexate, it inhibits dihydrofolate reductase. It has shown to produce anti-inflammatory and immunosuppressant property. So folic acid deficiency can lead to megaloblastic anemia, so we supplement folic acid with methotrexate. Another problem with that drug is hepatotoxicity. So we know that, so what we do is we regularly monitor LFT. So liver function should be monitored when we put a patient on methotrexate. What are the other conventional therapies what we have? The other conventional therapy is a drug by the name sulfasalazine. So when sulfasalazine is taken, sulfasalazine is split into 5-amino salicylic acid and sulfapyridine. So what we get is sulfapyridine, and sulfapyridine has the anti-inflammatory property, and that is the one which is utilized for rheumatoid arthritis. So this is the one which is used in the management of rheumatoid arthritis. If I want to correlate this 5-amino salicylic acid is basically used in the management of ulcerative colitis. UC stands for ulcerative colitis. The name is called sulfasalazine. So sulfapyridine is having anti-inflammatory property, and it is used in rheumatoid arthritis. 5-amino salicylic acid is used for ulcerative colitis. Now, since it is derived from sulfa, it is contraindicated in patients who have sulfa allergy. That is the second agent. The third conventional drug is leflunomide. Very, very important drug, leflunomide. What is the mechanism of action? It inhibits an enzyme called dehydroorotate dehydrogenase. Now, this enzyme is important for de novo pyrimidine synthesis, and if you inhibit the enzyme, there is decrease in T cell and B cell proliferation. So that is the mechanism of leflunomide. So until now, we have discussed three drugs: methotrexate, then sulfasalazine, leflunomide. These are the three important drugs which most of the rheumatologists will start. Apart from this, what are the other drugs we have? Is a drug by the name hydroxychloroquine. So not so much efficacious compared to other drugs what we have discussed, hydroxychloroquine. It also has anti-inflammatory property. But the major adverse effect when we start hydroxychloroquine, remember the E. So remember, whenever you think of hydroxychloroquine or chloroquine, remember E for eye. In the eye, it can produce the bull's eye maculopathy. So it can produce bull's eye maculopathy if you are using it for a very long period, and also it can produce in the eye corneal deposits. And one more E, whenever you think of hydroxychloroquine, is ECG. What does it do? In ECG, it causes QT prolongation. So whenever you think of hydroxychloroquine, think of adverse effect E and E. And also, it can cause pigmentation of nail and mucous membrane. So that is about hydroxychloroquine. Then apart from this, we also use the anti-cancer drugs, but not so commonly used. The anti-cancer drugs are azathioprine. Azathioprine is not the first line drug. We reserve it in the end. And also we use immunosuppressant drug. And it is a calcineurin inhibitor. So what is the name of the drug? It is called cyclosporin. And cyclosporin is an immunosuppressant. It inhibits calcineurin. The older drugs, conventional drugs, and not used nowadays, they are called as gold salts. So gold salts were used earlier, but they had so much of adverse effect. Even penicillamine was used. So guys, these are the drugs what we use as conventional DMARDs. But please keep in your mind methotrexate, sulfasalazine, leflunomide. These are the first 3 therapies which we use whenever you diagnose a patient with rheumatoid arthritis. The other options are hydroxychloroquine. Then we have anti-cancer drug, that is azathioprine. So azathioprine basically is used as immunosuppressant, and after metabolism it will give rise to 6-mercaptopurine. And calcineurin inhibitor is cyclosporin, and the older drugs are gold salts and penicillamine. Then coming to the biological agents. Now biological agents, what are the biological agents we have? So let me write the drugs that are TNF alpha antagonist. So TNF alpha antagonist, you can remember the mnemonic ICH. So similar to ICH, it is ICH. So I stands for infliximab. So MAB means monoclonal antibody. Then we have certolizumab. Then A for adalimumab. Then G for golimumab. Now remember, all these drugs are monoclonal antibodies, and you can identify they all end with MAB. The non-MAB, the drug is called etanercept. So it is called etanercept, and it is a non-monoclonal antibody. It's a non-MAB. So these are TNF alpha antagonist. Now once we are done with TNF alpha antagonist, the next biological agent is the interleukin-1 antagonist. The interleukin-1 antagonist, the name is called anakinra. The name itself is telling you interleukin, so it has kin in the name, and it's used for rheumatoid arthritis RA. The other new drugs which are come to the market are rilonacept. It's an interleukin-1 antagonist, and one more drug is called canakinumab. So these are the interleukin-1 antagonist. Now please understand, in rheumatoid arthritis, majority of the question is based on the mechanism of action. How do they work? What is their blocking? Interleukin-1 or TNF alpha antagonist. The next group of drugs which are used are the Janus kinase inhibitor. So we call it as Janus kinase inhibitors. So in short, we call them as JAK inhibitors. So the name is called tofacitinib. It is called tofacitinib, and it is shown to specifically block JAK1 and 3 inhibitor. Then we have a drug called baricitinib, and it has shown to inhibit specifically JAK1 and 2 inhibitor. Then we have UPA, UPA government, UPA dasatinib, and it is also JAK inhibitor, but not specific to 1, 2, 3 like that. So these are Janus kinase inhibitor. So number one, TNF alpha, interleukin 1, and then JAK inhibitor. Then next we have the interleukin 6 antagonist. Interleukin 6 antagonist. So most of you know that because of COVID, the drug is called tocilizumab, and one more drug is called sarilumab. So you can remember by the mnemonic SAT. SAT means 60. So 6. So sarilumab, this one, T for tocilizumab. So these are against the interleukin 6. And tocilizumab was also used in the management of cytokine storm. Cytokine storm in COVID-19. The name is tocilizumab. So that is D. Then we have CD80x86 inhibitor. So this CD80x86 is called co-stimulation. So we also call them as co-stimulation inhibitors. Minus sign means inhibitors. So they are called abatacept, and one more drug is called belatacept. Then we have a drug which is against CD20. It's a monoclonal antibody, and that is called rituximab. So these are the biological agents. The problem with biological agents are very good, but the problem is the cost is very high. So cost burden is the patient should bear the cost. That's the problem. So moving back, what are the targets of biologicals? Number one, TNF alpha antagonist. Next, we have interleukin 1 antagonist, interleukin 6 antagonist, the JAK inhibitor, CD80x86 inhibitor, and then we have a blocker of CD20. Now, whenever you diagnose rheumatoid arthritis, so what is most of the guidelines will tell us to start with methotrexate. So methotrexate should be started if the patient is not getting any symptom remission. Then you can add either leflunomide or you can add sulfasalazine. So this can be done. So still the patient doesn't get any remission with this, then the biological agents are added or they are replaced. So biological DMARDs are added. So this is how the management is done. So it's in a simple manner. So always remember, the first thing to start is methotrexate. You can add leflunomide, sulfasalazine. What about hydroxychloroquine and all? They are not used. Only if it is refractory, then only we use it. So initially we don't use it. Initial drugs are this. Patient is not responding, then we go for biological DMARDs. Even if that is not responding, we change the biological DMARD. That's what. If the patient is TNF alpha antagonist, we shift the patient to interleukin 1 antagonist, or we shift the patient to interleukin 6 antagonist, like that. So it depends on person to person. So in this video, I discussed the drugs and the pharmacotherapy of rheumatoid arthritis. Remember the pain, NSAIDs, then the breath therapy, steroids, then DMARDs, two types, biological, non-biologicals. Non-biologicals are also called as conventional. We have methotrexate, sulfasalazine, leflunomide, hydroxychloroquine. Then we have the immunosuppressant, that is azathioprine and cyclosporin. The older drugs are gold salts, and we have penicillamine. Biological, TNF alpha blockers, interleukin 1 blocker, interleukin 6 blocker, CD80x86 blocker, then CD20 blocker, and the JAK inhibitor. So these are the drugs for rheumatoid arthritis. Thank you all.